Okay, so good morning, everybody. Sorry about the little bit of technical difficulties there, but welcome to today's educational webinar on wound care. So my name's Kathy Arsenault. I am the practice consultant for the Association of New Brunswick Licensed Practical Nurses. And I'm just going to be serving as moderator for today's session, as Nancy is the wealth of information on this topic for today. So I have to say we're absolutely thrilled with the number of participants that we have joining us today. This is probably our largest attendance to date for a webinar, and I know that there's some groups in workplaces that are joining together today, so the numbers are even larger. However, we're not surprised with the amount of people registered for today's session, because wound care has definitely been our most requested topic for LPNs to have education in and want courses in. So with that being said, obviously we're very grateful that Nancy has taken time out of her very busy schedule to provide some of that education to us here today. I think many of you are probably quite familiar with Nancy, our facilitator, as she's been with Horizon Health for several years. She's a very well-respected nursing professional, and she's done a lot of presentations on wound care in the past. So probably a lot of you have seen her speak before. Nancy Schuttenbeld is a nurse specialized in wound, ostomy, and continence Canada, and she's practicing in Area 3 in New Brunswick. She did begin her nursing career by graduating from the St. John School of Nursing in 1990, and she was employed at the St. John Regional Hospital and the Ottawa Civic Hospital before returning to Fredericton. Nancy returned to school for her Bachelor of Nursing and then ICU certification. She later returned again and received her Master's of Nursing and her next specialization in wound care. So Nancy's passions are prevention of pressure injuries and wound pain. I'm just getting over a cold, my apologies. She has been employed in nursing for 32 years, and she still loves the profession. She is the mother to 3 young adults and a 2-year-old German Shepherd Russell. She loves the outdoors, especially biking and kayaking. So please do join me in welcoming Nancy Schuttenbeld. We are very happy to have you joining us today, and we really look forward to your presentation. Before Nancy kind of takes the wheel here, I have a couple of poll questions that she just wanted to kind of get an idea of who is joining us today. So if you can just watch your screen here, I'm going to launch a couple of polls to you if you wouldn't mind participating. So you see the first one is just asking you, what is your professional designation? So if you could just click off if you're an LPN, RN, PSW, or other. So I'll give you a few seconds to do that, and then we'll share the results. And also, there'll be quite a few polls in this presentation, but we don't see your name, so you don't have to worry about your name flashing across the screen. It will just come in as a percentage. Okay. So just give you about 5 more seconds, please, if you wouldn't mind participating. All right, so I'm going to end the poll here and share those results. So we have 110 are LPNs, and we have 12 that are RNs of those that have participated. So I'll give you your next poll here. And if you can answer this next question, is just asking how long that you've been employed in healthcare. So there's a variety of options there to choose from. They're still trickling in. 5 more seconds. Okay, so I'll share those results with you as well. So we're a little bit all over the map here, but mostly 20 plus years of experience. Bravo, about 26% of our participants. And then we've got 10 to 15 will be the next highest, and 15 to 20 at 16%. And we have about 11% are brand new, 0 to 2 years. So that's great. And just one more poll question for you before Nancy starts here. And so how many hours of wound care education have you received in your program? So in your nursing programs, I guess. Okay, 5 more seconds. If you could just click off your answer there. All right. And so, as you can see, I guess the highest amount says they've had 6 or more at 36%. And then 2 to 4 hours at 24%, 4 to 6 at 17, 20% had 1 to 2, and then we have a small percentage that have not had any, about 3%. Okay, so I'll take that down and on to you, Nancy.
Okay. Thanks so much, Kathy, for the invite. I could probably learn more from you folks than you'll learn from me, but hopefully I'll provide some tips and information today and we'll learn from each other. So I sent 3 PowerPoint presentations. The first thing we're going to talk about for the first half an hour is the assessment of wounds and the need for a documentation tool. Is there any way, Kathy, we can ask the audience how many people use a wound documentation tool in their practice?
Yes, so I had that as one of my polls. I forget which slide that was on.
Okay, as long as it's coming up, that's
Yeah,
awesome.
okay.
Okay.
I had little sticky notes where you had told me when to ask that. So
Okay, perfect, perfect. So thanks everybody. So we'll be doing that first. Then we'll look at common wounds products. And if anyone wants a copy of the tool that we use in Horizon for documentation, it's the same tool that's used in home care, and it could certainly be used in long-term care areas. So I can share that and send that to Kathy if anyone would like it. Also, the second section, we're going to go over common wounds and products. And again, I would like to keep this as interactive as we can virtually. I appreciate everyone's time for coming today. And we do have like a product picker that I'm going to go through with you that we use here in Horizon. And it's also used in the extramural program. And we're certainly willing to share that. I see in the next year adding a few more products to it. Meta Honey is a product that's come out that's done a great job with wound healing the last several years that we need to add, as well as a few others. And we'll be talking about that, and hopefully I can get some input from you as well. We'll take a nutrition break, 10:15 to 10:30, and then after that we'll talk about skin care in the elderly, and particularly skin tears, which are quite common in the elderly population in long-term care settings. So I hope I cover your needs, and if I don't, please let Cassie know what you would like or what I could do differently in the future. So I look forward to a great morning of learning with you. And if you're like me, we're not used to sitting down, so stand up at any time and move around in your houses, do what you need to do, and hopefully we'll all learn together. So I'm trying to move this forward here to the next slide. And forgive me. Okay, here we go. So wound assessment treatment flow sheet, assessing and documentation, communicating with consistency. And that is why we left Lifton's 3. Like, if we don't document our wounds consistently in one place, be it a pressure ulcer that's developed on someone's coccyx or heel, we tend to do narrative notes in either the progress notes, the communication notes, the nursing notes. And then it tends to be very subjective. So really important. Gee, it's hard to move these slides ahead. Can you, I'm hitting the enter button. Okay, there we go. So again, why
just let me know when you want to advance, and I'll just do it from my end. Yeah.
Perfect. Thanks, Kathy. So we're looking at a documentation tool will give us objective data versus subjective data. When I started working in wound care, I learned from the best, Kathleen Esligar. If anyone had the privilege of working with her, she's amazing. And we would see a patient's wound, someone had developed, oftentimes, unfortunately, it was a pressure ulcer that they developed, or injury, we call them now. And we would revisit it a few weeks later, and I might think it improved, and she didn't, or vice versa. So we recognize the importance of having a documentation tool that measured the wound and that would tell us, like, is it getting smaller, deeper, changes in the base of the wound, is it more red and pink, or is it more slossy? So really it is, you need it for objectivity. It provides continuity so that if you're off for a week and you come back, you can look at that wound and look back at that sheet and see the difference. It gives us a clear common language, and it certainly takes away from having to do a lot of narrative notes in the nursing notes. So I hope that makes sense, and we'll go to the next slide. Okay, so what kinds of wounds would you use a wound documentation tool for? So it would be any wound that the physician or nurse practitioner has an order for a dressing change, or the NSWAC, which is our role of nurse specialized in wound care. So if there's an order for a dressing change and a wound management plan, you should use a wound documentation sheet and initially record the wound when you see it, and then continue to use that for documentation and measure that wound weekly. If it's a chronic wound, with chronic wounds that are, we have one lady, she's had one for 6 years now. She had a lobectomy, excuse me, and the wound goes up 6 inches one way, 6 inches down another way. And she's had this open wound for 6 years, so we certainly don't need to measure that one weekly, but we should probably measure it monthly. And P.S., they're hoping for a skin graft for her finally. Also, the other question that comes up from colleagues is, if my patient has 2 wounds in one area, can I use the same sheet, the documentation tool? And if they're like wounds bigger than a couple centimeters, we say use a separate sheet. But if someone's got like a wound on their lower leg and then they've got 8 little ones around it, we're certainly not going to use 8 sheets. So use one, and I say document on the biggest wound. Okay, so I hope that makes sense. So the documentation tool is certainly not for insertion sites or tubes, drains, lines, or intact incision lines. You'll see a lot of people who have hip fractures and they still have their clips in, or they have their sutures in. They want to keep them in for an extra long time. Well, certainly you don't need a documentation tool for that. So we'll move ahead. Okay, so this is the one that we use in Horizon that Derek and many of you who've worked in Horizon would be familiar with. And again, willing to share it with any long-term care facilities, any other facilities out there, special care homes that would see it as beneficial, and take the parts that you need and adapt it to make your own sheet. But I would ask you to keep the core components that you need. So if you look at it there, maybe we'll go to the next slide to see. So the first thing we look at with a wound is, what is our goal? We have many patients in the community and in hospital, in long-term care center, that is just to maintain that wound. There's a gentleman who lives in long-term care now. I'm not sure if any of you guys are involved with him, but he was shot at in the war many years ago, and he has a wound to his lower leg that you can visibly see the bone. And that wound has been there for 30 years and will be there for as long as he is on this earth. It failed at grafting, it failed at closing. So it's an open area on his body like our ear would be. And he changes the dressing a couple times a year, a couple times a week, and he maintains that wound. So you have to think, do we want to heal that wound? Do we want to maintain it? Or is it non-healable or palliative? And look also at the age of the wound. Anybody have any ideas what kind of wound that one is, just for fun? I wonder if they could put it in the chat screen.
Yep, and I see we have a poll question attached to this one. Do you want me to launch that now? Maybe that's what you asked
Sure,
in the poll.
sure.
Let's do that first. Okay. So I guess your question to them was, is this wound healable?
Oh yeah,
Yes or
yeah,
no?
yeah.
So if you guys can just take a moment to answer that. Oh, it's a tight race here. It's great to see so many people participating. Give you a few more seconds to answer yes or no. And again, it just comes in as a percentage. So don't worry if you're wrong. We won't see your name or anything.
And there is no wrong or right. We're always learning together, and I learn every day, and I learn from all of the people who are participating today.
Okay, so I will, oh, another answer coming in there. So I will share the results here. So 65% say yes, it's healable, and 35% say no, it is not.
Okay, interesting, interesting. Is there any way, Kathy, we can ask if they know what type of wound that is?
Yeah, if you guys just want to pop that into the Q&A box, if you know what kind of wound this is.
And we'll give them a couple choices: surgical wound, pressure ulcer, or accident.
Okay, so if you guys want to pop that in. Okay, so we have a couple votes for pressure injury and pressure ulcer. Let's see here, they're coming in feverishly here. So lots for pressure injuries, couple for accident. So we kind of have a split between pressure ulcer, accident. Somebody does say surgery. A few more say surgery. So we're all over the place here. Vascular
Okay,
ulcer.
awesome. Okay, so for those of you who said, is it healable? Absolutely. This wound is 100% healable. And the reason why is the patient has a hemoglobin above 90, which gives it enough blood flow to heal that wound. Um, you can see by the appearance of it, it's red, it's got some nice granulation tissue. If you look close at it, it's almost got a little bit of a grayish sheen on it. So what you would do with that, if you saw that, you'd take a little bit of normal saline on a sterile gauze and just kind of see if you can scrape that little bit of biofilm off. And then you would get down to healthy tissue again. This actually is a pressure injury that developed in our hospital here at the deck, and it went down right down to the bone. The patient was compromised, didn't move, didn't want to move, and ended up with a pressure injury right on that coccyx. And it went down to bone and got infected, of course. So we put them on antibiotics, and we cleaned out and cut out the what I should have showed a before picture, the gray eschar and the purulent drainage and everything. And then we put in a solution which is called Dakin's, which is basically bleach. We packed it into the wound, and if you ever get orders for that, the most important thing with that too is to make sure you put Vaseline around the peri-wound skin to protect it. That cleaned up all that slough, and then we put vacuum assisted suction over the area, which is a ridiculously expensive machine, but it does pull the wound and helps it to close. We would put them on a high protein diet. Many people who don't have a great appetite, especially the elderly, we would give them like 2 cal or something to boost their protein, boost their calories to help that to heal. In this case, this lady was feeling better, got better, eating a little bit better. We boosted her up. I think we used Boost and 2 cal. Her hemoglobin was above 90, so high chance of healing. And she was able to turn in position. The biggest thing is offloading ulcers. Offload, offload, offload. If that's the one take home message I can say to you, is nothing more important than keeping them off a pressure injury if they get it. So you can see it's nicely, it's coming along nice, and we were going to put that vacuum assisted suction on for a couple more weeks, and hopefully heal it so that we can put a regular dressing on. So thanks for answering that. We'll go to the next slide. Okay,
You
so
have
type
a,
of,
sorry, you have a poll question for this one too, so just let me know when you want to launch it.
well, you launched that poll, Kathy.
Okay. One more question, I guess. Okay. So again, just asking what type of wound is this? Is it a tumor, pressure injury, diabetic, or skin tear? Okay, they're still coming in here. Maybe a few more seconds. All right, I'll share those results. So most people are going with skin tear at 75%. Second highest is pressure injury at 15, diabetic 8%, and just 2% said tumor.
Well, kudos to all of the people who chose skin tear. Awesome. That is a skin tear on a patient last week, and she had an epidural in, and when they took the tape off around it, it tore her skin. There was a little bit of skin that came off with the tape, and the rest of the skin came off too. And what it is, it's going back to the vulnerability of our skin as we get older. Is it tends to become thinner, and we'll go through this in a later lecture, but much more prone to skin tears. So that's exactly what that is. Anybody have any ideas of what you would put on that or do for that?
So if you just want to type it in the Q&A box of how you think you might treat that, and I'll read a couple of the answers out. Also, in the when you put in the chat box or the Q&A box, or you can always choose to send anonymously if you're shy. So somebody has said Medi honey, Bactigras dressing. Somebody says cleanse it, an opsite, leave it open to the air, Jello net, Bactigras and Telfa, Vaseline, opsite, cleanse and cover with the non-adherent and Telfa. Opsite, so again, normal saline, Vaseline for the Bactigras,
Okay, so
Tegaderm. Yeah, all kinds of options here.
all kinds of great answers. Um, the only thing that you really want to be careful of is that whatever you put on that, is that it doesn't stick to it and create more skin damage. This is an elderly lady in her 80s, and so I'd be real careful about Telfa. If I was going to use Telfa or gauze, I would make sure that whatever I put underneath it would be thick enough so that that dressing didn't stick to it so that it's harder to take off. And there's no one right answer you can use for that. No one said flamazine, which kind of surprised me. I don't think it would hurt to throw some flamazine on that for a few days. And as you know, flamazine is used for burns. Still to this day, not as popular as it once was, but it's got where it has the silver in it, it would prevent it from getting infected. I don't think I would leave it open to air. You probably could. I would just be afraid where it is open and there'd be a little bit of serous drainage, that if you left it open to air, you might get a chance of like their material, their clothing sticking to it and that. I like the people who suggested polysporin. That would definitely work. Then you could put a Telfa over that. I love the idea of a Bactigras. Bactigras is a nice woven dressing, as you know. It's got almost like a Vaseline embedded, but it also has some chlorhexidine. I think it's got 5% chlorhexidine, so a little bit of antibacterial in there. So if you put a Bactigras on that and then tacked it lightly with you could use paper tape gently or Hypofix very gently. Actually, it was hypofix that actually caused that. So avoid hypofix. But I know myself when I was going through my cancer treatments and I had a big radiation burn across my chest. And when I took the paper tape off for the doing my own burn care, I ended up the paper tape, because my skin was so fragile, ended up looking like that. And so be very cautious when you're taking, if you have to secure it with the tape, that when you go to remove that tape, I would wet it with warm tap water to help remove the tape. The other thing I'll do is I'll take some Vaseline and I'll kind of pry it underneath the tape so that when I'm taking that tape off, I'm protecting that skin. I also use polysporin or warm saline, but as we know, tap water has some saline in it too, so you can always use that. So back to grass is a great answer. Gelinet's a great answer. Vaseline's not a bad choice either, less runny than polysporin. Polysporin, you could use some flamazine. You could use Meta Honey too. I don't know if it's deep enough or anything that it needs it, but again, it's an antibacterial. And you could actually, if you use the Meta Honey Barrier Cream, would probably be a great choice. So there's never one right answer for these wounds. You look at the wound, try something, and when you try something, try to leave it in place for 2 weeks, unless the wound takes a significant dive downwards. Because I find that we all have opinions and we're all curious about wound care, but if we don't give it a chance to work, is to give that a chance to work. So thanks for answering that. We'll go to the next slide. Okay, so if a pressure injury, stage 1 is unblanchable, stage 2 affects the 2 layers of the skin, stage 3 goes further, stage 4 goes to tissue, bone, or tendons, and unstageable means that you really can't see the base of the wound because it's got eschar, slough, or something there. Or could this be a suspected deep tissue injury?
So I'm going to poll for this one as well. Do you want me to do that? Getting everybody thinking this morning. So what stage is this pressure injury? 1, 2, 3, 4, unstageable? Okay, we'll give you a few more seconds to answer. We've got a tight race here. People are thinking.
It's a tough one.
Yeah.
And you can, you know what? I really would give, I'd give yes to two options.
Okay. All right, I'll share these results here now then. Okay, so most people are going with stage 4 at 40%, and then it's pretty tight between stage 3 and unstageable. So 29% think stage 3 and 26 say unstageable.
Okay, perfect. Those are really great answers. And I can see why you would choose unstageable, because if you look at the center of the wound, there's almost like, is that yellow slough? Is it eschar, or is it part of the patient's skin? It's actually part of the patient's skin. But again, you could get away with saying unstageable because it's really difficult to tell. Stage 4 could be a possibility, because if we put a little Q-tip in and probed around, it might be deeper than we think. It might actually be full thickness loss and go to fascia, muscle, or tendon. Or it could be just this, not just, it could be a stage 3 with full thickness skin loss in which the fat is visible and the edges are rolled a little bit. And you can see that the edges are just kind of starting to roll a little bit. And that, unfortunately, again, is a coccyx wound that developed here in Freddie Beach. Thank you. We'll go to the next slide. Okay, so we talked about with the wound care documentation tool and having a plan. I'd recommend that we leave that plan in place for 2 weeks whenever possible. Give it a chance to work. List the products used, how often the frequency of dressing changes, if they are on antibiotic or not, and the rationale for change in progress notes. Do we have a question on this one, Kathy, or no?
Yes, we do. Yep. So I'll
Okay,
bring
awesome.
that up.
Kathy, you're like Vanna.
So what type of wound is this? Arterial, pressure injury, venous, or diabetic foot wound? I laugh at these pictures. Only nurses would have coffee and muffins looking at all these gnarly
Yeah.
wounds and not be affected by it. It's a great way to spend your morning. All right. So I think people are really thinking about this one. It's a little bit slower reactions here.
Go with your gut instinct. Look at the location. There's your hint.
Yeah. All right. So I'll share those results. Yeah. So 90% went with the
Perfect.
diabetic foot wound.
Yeah, definitely. And you know what? There probably is some venous insufficiency involved, as there often is with diabetic foot ulcers and circulation. But you can see that that patient has on that second toe, it's indented, probably probes the bone if you can see that little indent, and on their great toe. What's significant about this wound, it is a diabetic foot ulcer, so kudos to all of you. And I'm sure there's some venous insufficiency involved with circulation as well. But and I really didn't capture a good picture of this. This patient came in last week, um, and one toe, we'd seen him the week before. That second toe was open and infected, and he was treated with antibiotics orally, and we were doing wound care on that. And you can use, I think you can see, we were probably using Inidine from the orange around it. But he came back the next week, and look at that great toe. It's huge and it's red. And so I sent that right away to the doc, who got an x-ray done, and it turns out this patient has osteomyelitis. So when you see a diabetic foot ulcer, when it gets red like that, even though the wound on the outside doesn't look half as bad as the bumps we just saw a few minutes ago, be on high alert, because when it's red like that, chances are it's infected within. This patient ended up having osteomyelitis and has had that big toe and the next toe removed. And the fear of not treating that right away and getting that second opinion, getting the doctor involved, or nurse practitioner, I guess, could probably do the same thing, getting an x-ray and having it explored, is that this person could have lost their entire foot if we had just continued to do wound care on it. And this young man, he's ambulatory, he's in his 80s, but by losing that great toe and the next toe, he still has the sole of his foot and his metatarsal bones. So he'll still be able to walk, and that's very important. So thanks for voting on that, and we'll go to the next one. So when you're measuring your wound, you want to do the longest part of the wound, the widest, and the depth. There's two tools that we use, and hopefully you have them in your practice. These are super cheap. They're my Medline. I don't know if you can see that. And it's just a Q-tip that we have. They cost pennies. The nice thing it has is a ruler on the outside. And you can also get these by Puritan, and I'm just sharing what we use. The thing that I love about this one, I'm going to open it up. If you can see, it's got, it's almost better if I pull it back. It's got the numbers right along, and it's got, it's sterile, of course, not anymore, and it's got a foam tip. So if you get any wound with any depth, you can exactly measure it. So about those clocks, so when you have a wound, you go with a clock and think 12 o'clock is here, 6 o'clock here. So if I've got a wound, a pressure ulcer on the bum, and it's 4 centimeters long and 3 centimeters wide, and goes in half a centimeter deep, and maybe it tunnels a little bit. Where would it tunnel? If I said here, it'd be tunneling at 12 o'clock, or write it or record it as tunneling at 6 o'clock or 3 or 9 or wherever it does, okay? And the wound bed, what does the inside of the wound bed look like? Is it red, pink, granulation, slough, eschar? We do that in percentages and take an estimate. And these are things that should be part of your documentation tool. And like I said, we can certainly share out our form and adapt it to your facility. Hopefully you will never have any wounds, but chances are in reality, you do have one or two, or may have one in the future. So using that tool, measuring it weekly, and as a documentation tool. We'll go to the next one. Okay, so
So
wound locate.
yeah, I think this is where you had wanted to ask the question as well.
Oh yeah.
Okay.
Go ahead, Kathy. Sorry.
Yeah. Don't mean to interrupt you.
Please do.
Okay, so you had asked earlier, do you use a standardized documentation wound tool in your practice? Yes or no? Okay, let's give you about 5 more seconds to answer.
Sorry.
All right, I'll share those results. So it's actually pretty tight. I mean, majority do at 59%, but we do have 41% that don't.
Okay. Well, that I'm happy. That's a lot more than I thought. So that's awesome. And again, your tool should be simple, easy to use. I find ours the font a little bit too small, but I'm getting old. Um, but it's important that if you do have a wound, the patient comes in with a wound or has developed a wound, that you record it. So you're looking at lengths, widths, depths, any sinus tracting and undermining. So the difference between undermining and sinus tracking is undermining it, just like you have those rolled edges and it goes under a little bit. Where tunneling, it's deeper. You're going down more than just those rolled edges and that. One really important thing that we need to work on in our healthcare system is getting rid of those soaker sheets that we use in the hospital everywhere, because they've been deemed unsafe by WorkSafe New Brunswick because of the friction and shearing. And I grew up with them. They are wonderful for turning and positioning, but they do create a lot of friction and shearing. Instead, we've invested in lots of those Swift Breeze sheets. So they're slippery blue on the outside and they're cotton white on the top. So they're much easier. You avoid that friction and shearing when you're turning and repositioning your patients. And they're much safer for our back. So just a little tip there, and we'll continue with the next slide. Okay, so the wound bed, if we look at that one, do we have a poll question for this one?
We do. Here
Okay, awesome. So I'm just going to talk for a minute about your wound bed. Usually it's pink red or there's some slosh. Eschar means dead tissue. Granulation, red pebbly. The old term used to be proud flesh, and it was just almost hypergranulating. Foreign body. I've been asked to see wounds where we had one lady in our long-term care waiting for a placement, and on her upper chest, you could look and you could see her pacemaker, and there was just a little piece of skin covering it. But she refused to have it fixed, grafted, or whatever, so we just covered it for safety. So sometimes you'll see some hardware there. Sometimes you'll see fascia, tendon, and bone. Other times, if it tunnels deep, I saw a wound yesterday, and 95% of the wound I couldn't see. It went down 4 inches. I could only see the top of it. So, and then you add that on your chart to be 100%. So if we look at this wound in front of us, and the question is, Kathy? I don't remember.
So there's a couple there, actually. The first one is asking what type of wound is it? So surgical, venous leg ulcer, or pressure injury. And you can answer all of them. And then from the picture only, what percentage of red pink is present? And then what percentage is eschar and what percent is underlying structure? So I'll give you a moment to go through those 4 questions. We'll give you a little bit of extra time because there's 4 there and there's lots to think about there.
And just to take a quick guess, we're going to go through it.
Okay, they're coming in here.
And everything that I asked, that everything we discuss in today's lecture or presentation, I hope it's not a lecture, I hope it's more interactive than a lecture, that is all confidential information. We all, wherever we're working, we're under an oath of confidentiality, and we're sharing these slides and these pictures and these patients' experiences to learn from each other. But I ask that they not be shared, the pictures, with anybody, or the information that we shared about their stories today. I know it's a given, but a reminder to all of us.
Okay, I'm going to end the poll and maybe we'll just take these one by one. So the first one, what type of wound is this? 89% went with venous leg ulcer. So true or false, Nancy?
You're not going to believe this, folks, but this was a pressure injury.
Oh,
This was
wow.
a man who laid in bed and he just kind of lost his zest for life. And he laid in bed for extended periods of time. And that is a pressure injury, if you can believe it. Yes, definitely there's some poor circulation involved. He was elderly, but only in his mid 80s. But that primary is pressure injury. There is a little bit of venous leg ulcer, but you can see it's on kind of on the back of the leg. Venous leg ulcers tend to be on the front too, the majority. So what percentage is pink red? Yeah, I would agree, 30 to 40% for sure. Yeah. And
So
then our
most
next
went
two
with
questions.
60 to 70 for that one, but you're saying it's 20 to 30?
I don't know. I get it. Can I move that over so that I can see the wound again?
Oh, I wonder if I can. Does that help?
Yeah.
Okay.
Because your results are kind of covering our slide.
Oh, I moved it over there. Can you?
Okay, I can't see it. But
Oh, okay.
if most says 60 to 70, I'm sure. When you
Okay.
take this down, we will oh yeah,
And
there it is.
then,
Oh yeah, definitely 60 to 70. Yes,
okay.
definitely.
And then what percentage is eschar? So 57% went with 10%.
Mm-hmm. Yeah, I think you're about right. Can you see my arrow pointing on the wound?
No.
No. Okay. So if we look at the wound, 60 to 70 definitely is red. That what looks like, and you're thinking, what is that on the lower part of it? That's actually his tendon. And you can see the black part of it, it's dead. So there's no way we're going to revitalize that tendon. As the wound healed, what happened is we eventually just cut it out as more granulation tissue and everything filled in. And the eschar is about 10%. You're correct, that black, yellow, slossy stuff. Yeah, it was just a man who had lost his will to live and laid in bed. It was really sad. Thank
And
you,
then the
Kathy.
underlying structure there, Nancy, what percent is
Yeah, and
underlying?
that is the tendon. It's a dead tendon.
Mhm.
You can see the black at the beginning of it, and then it's yellow. And that's what I said that we eventually, I didn't, the doctor eventually cut that out because it was non-functioning. Yeah, this, believe it or not, this wound did heal. It took
Wow.
8 months. I never thought it would heal. I thought he would lose his leg. He did not lose his leg, and it did heal. Of course, lots of discoloration and scarring, but it healed, believe it or not. But I was 8 months to a year, I'm sure. Yeah. Okay, so exudate amount, we're talking about how much drainage, and then on your chart, the amount, and then the type. Is it serous? Serous is white. Is it sanguineous, bloody? Is it purulent, or is it other? We have some wounds where they've developed a fistula, and we'll see bowel content going into the wounds. So I'll get you to go to the next slide. That's pretty self-explanatory. That should be part of any tool you have. Yeah. What type of
Yeah.
exudate is in that wound? That's another bum, unfortunately, here at the deck.
Okay, maybe a couple more seconds there. Great. Okay. So 83% are saying purulent slough.
You got it. Yeah, for sure. If you can close that so we can go back to the picture, you can see around it, it might have a little bit of serous in that, but if you look at the base of it, you see that yellow, and it was very slothy. Yeah, again, developed from not moving. Offload, offload, offload. Can't stress that enough. And we'll go to the next slide. Okay, so edges and peri-wound skin. So we're looking at if they're attached, if they're non-attached, rolled, curled under, excuse me. When you have a wound, no matter where it is, if those edges are rolled in, that's indicative to you right away that that's a chronic wound and it's been there a while, at least a month. And if we get pink, purple, shiny skin tissue, you wonder if there's some damage to the besides the area of the peri-wound skin. Next for the peri-wound skin, excuse me, is it intact? Is it reddened? Is it indurated? Is it macerated? If it's macerated, whatever we're using, chances are we're keeping it too wet. Is it excoriated? We'll get some excoriation with some incontinence-associated dermatitis. Is it callous? Do we need to get rid of some callus? And is it fragile? We had a patient, she was 99 years old, little tiny wound, fragile wound. So if we look at, do we have a question for that one?
Yep. So there's a couple. Wound edge of the 4 choices, which is this wound? And peri-wound skin, which number best describes the peri-wound skin? They're thinking on this one.
And you can see with peri-wound skin, check all that apply, and even wound edges, all that apply.
All right, I'll share those results with everybody.
Okay, so epithelialization for sure, yeah. 1, 2, 3, 4, excuse me. Yeah, there is some rolled curved edges. You can see that. It's kind of hard to tell. And it does appear to me to be non-attached. Peri-wound skin. People are saying it's erythema and the redness around for sure. And it's also very fragile as well. So great answers. Thank you, everybody. Yeah, offload, offload, offload is our one of our solutions for healing that one, isn't it? We'll go to the next slide. Okay, so packing. So just remember, if you've got a wound that you're packing, what you take out, make sure that you get it all, and use only one piece. We had a wound on someone's, I think it was their abdomen, and they had had 3 things of packing in there. Try to avoid that because you can lose it if it's underneath and things like that. I know it sounds like you can never could, but you can. And I would think about if you're packing it, oftentimes they're packing it with soaked normal saline or half saline and betadine or PHMB. And if I have to use more than one of my ribbon, I would think about taking some Curlex and putting that in as one piece, because once that is wet, it can go really small. Or the PHMB, that's the antimicrobial. And I don't work for any company. These are just products that this one works really, really well. But try to always only use one piece and leave a nice big wick. We had a lady that had bowel surgery, and there was some packing to her rectum, and was not removed when she left the hospital, and she came back to see her physician 3 weeks later, and she just very, very foul odor. And when the colorectal surgeon examined her, had found some old packing that had been in there for 3 to 4 weeks. So I had to put her on antibiotic, of course, remove the packing. And she did certainly heal and was okay, but it could have been a lot more serious. Again, an error on visualization of the care worker for not exploring that wound and getting that piece of packing out. So again, use one piece and always leave a long wick, and then that way it's you protect yourself, you protect your patient or resident. Next slide. Okay, so how would you measure and treat? I'm just looking at our time, and we're way over time, Cassie. So do we have questions for this one?
We did, yeah. We'll launch that quickly for you.
Yeah, and we'll go through this quickly.
So just asking what type of wound this is again: surgical, pressure injury, accident, or fall with cut.
And I think the treat, I think I'll just answer that out loud if that's okay in the essence of time.
Yeah, I'll
But
just
there's so many
launch this
choices.
there. There we go.
Well,
Most are saying pressure injury.
yeah, for those who, the 38% who said pressure injury, you're right on. And if we can close that, Kathy. If you look at the location, can you tell that it's the back of her knee? And what had happened, it was a patient who was paraplegic, a highly, highly educated lady who had an old wheelchair, had moved to a new province and spent her money on her condo and didn't have the finances for a newer wheelchair because she didn't feel in her legs. That is the back of her knee from rubbing against her wheelchair. So, I'd love to pose the question. So think about in yourself, well, how would you treat that? So first of all, you want to clean that up a little bit more. Maybe see if you can get rid of that gray at the top of that. Think that you could put in to help to manage it and treat it. You could use negative pressure wound therapy, the sponge with a little machine. They can be expensive, but it would certainly work. The other thing is you could put some Meta Honey. You could put Meta Honey Alpinatus, that tacky stuff. Put that all in. That would clean up that gray. Definitely get a new wheelchair, and she actually went on bed rest for a while to heal it. You could, I wouldn't use Aquacel AG because I think it's still got too much sloth and needs to be debrided more. You could even do Dakins, which is super cheap. Dakins, as we know, is diluted bleach. Again, you're going to put Vaseline around the peri-wound skin. Remember, if you're using Dakins, to only use it for 3 to 5 days and reassess, because you don't want to be using that, and because it will affect good skin as well. It's really, they say a lot of places really hesitate to use it, but to clean up a wound quickly, to get rid of dead tissue, it does work. We use it safely here in our facility, but we do it short term only. And you would change it 2 to 3 times a day. So I would recommend like a Meta Honey. You would put that in there. The other thing, you could use iodosorb. Iodosorb is kelahexamere, and that will debride and eat at that gray and clean that up. Um, you could also use half betadine, half saline, nice, inexpensive. Put some Curlix in that and do that a couple times a day. And this wound did eventually heal, FYI. We put some, I think, what we ended up doing, we debrided it, so we cut out the grayish areas that there, and then we did use Dakins for 3 to 5 days, and then we put on that negative pressure wound therapy where we put a sponge in to suck it and help the healing. And she was eating well, and we got her. Of course, she was out of the wheelchair on bed rest, and it healed quite well because she was only in her mid-40s. We'll go to the next slide. Okay, so type of wound, how would you measure? Did we have a question for that one, Kathy?
Yes, yep,
Okay.
here it comes. There's two there. So what type of wound is this? Skin tear, pressure injury, abrasion from fall or other? And do you regularly measure wounds
Yeah.
when doing wound care? Okay, just give you about 10 more seconds. Okay. So most are going with pressure injury and saying, yes, they do measure the wounds.
Oh, excellent. Awesome. Okay, we'll close that and we'll take a look at the wound. Um, yes, I definitely say pressure injury. You can see that the skin is really vulnerable, that they were laying on it too long. But I also think that this patient was happened with friction and shearing from pulling her up in bed. You can see how it's jagged, the edges in that. So she had very vulnerable skin, and it is a pressure injury. And you can see from the yellow that's on that they're using either iodosorb, which is a kelhexamine, which is an iodine compound in a paste. It looks like it comes out like a toothpaste on it to clean it up, or else they're using inidine. You can see that from the copper. Biggest thing we can do for this patient is to clean that up and offload and protect that skin. So we'll go on to our next one. And so I think we're coming to the end. Thank you for those who are using a wound tool, measurement tool, and assessment flow sheet. It does give you a proper assessment. It prevents errors. Measures those wounds weekly for 4 weeks. If it's a chronic wound, then monthly. And it's if you're not using a tool, I would highly encourage you to use a wound documentation tool. And I think that's it for that one, is it, Kathy?
That's
Thank
it
you.
for
Yeah.
this section.
So
Yeah, so I'll just,
how about if everyone has a stretch break for about a minute, and I'll pull up the PowerPoint, Kathy, for the next one, and we'll take about a minute break.
sure, yep, sounds good.
Okay, thank you. Thanks, everyone. So now, Kathy, I'm going to pull up mine. So thank you for coming back. I hope everyone's back. So the next thing we're going to talk about are wounds products and some pressure injuries because they're so prevalent. So the first slide you can see for our title is a pressure injury, and that is a stage 2 pressure injury because it's a blood-filled blister that was developed by a patient who, again, did not offload his heels. And when you're offloading, you have to offload the heels separate from the rest of the body, just FYI. That could have been prevented by putting a pillow lengthwise underneath his knees. So that did develop. So you asked, how would you treat that? We just basically, you can see we've got him offloaded on some towels there. You could paint that with betadine. We don't recommend breaking the blisters because when you do that and de-roof it, you increase the chance of infection. Obviously, the circulation is not 100% here. or for that to develop as well. So again, be very careful with what you choose to do. Some physicians are like, oh, I'm going to open that blister so it can heal. Well, the other thing you can do is you can paint it with betadine or just keep it dry, offload, offload, offload. You could poke a sterile needle at 90-degree angle and slowly press out the serous fluid, the serous fluid, but leave it intact. The most important thing is to leave that skin intact. And what will eventually happen is that will dry up and peel off. And that's exactly what happened. We used, because it was full of a lot of fluid and boggy, we knew that it would take forever for it to heal the other way. So we just took a needle at a 90 degrees. So we didn't go into the foot, but we went sideways, compressed the fluid out, and then it was all wrinkly and dry, and we just offloaded it and we painted it with betadine. Super cheap and easy, and big thing, offloading. He did have pedal pulses, so you want to make sure you do that before you even deflate that, and it did heal. So we're going to be talking about wounds, products, and pressure injuries. We'll go to the next slide. I wonder here. Okay, so this is the product selection guide that we use here in Horizon, and it's shared with long-term care, it's shared with home care. If anybody would like a copy, please let Cassie know and we'll send it along. It tells you your different categories and it gives you options. So if you're not sure, and again, as I've always said, is there's more than one right answer. There's not just one product that's going to heal the wound. And chances are, as our plastic surgeons will tell you, is wounds will heal naturally on their own as well, because if we're living, breathing, eating, chances are we can heal a wound. So there's no one right answer. So the categories for wound products, and you'll find this on any product picker, they go into the different types. And you look at your goals sideways. Do we want to protect the wound? Do we want to fill it? Absorb? Are we trying to hydrate that wound? Are we trying to debride it, clean off that dirty slough? Does it need antimicrobial? And how long can we wear that dressing? So this is what this wound product selection guide gives us. And we developed it with a team of about 18 people from home care and in hospital care. And we used Ontario's as a guide, what they had done. It got to the point where we had more products in our system, about 60, and even experienced nurses weren't sure what to put on a product. We had too many choices. But chances are there's many products that do the same thing. So we downsized it to about 20 products, and we didn't hear any flashback. But I do know now that we need to add a few more products as time goes on. So Tegaderm plain, you would put it over an IV site. If you want to protect vulnerable skin on their bottom, put it on, leave it on. It says up to 7 days. I would even leave it longer until it rolled off. So it's breathable, it's waterproof, and it can protect your skin, especially from friction and shearing if they need to be moved. The next one there is the Tegaderm Absorbent Clear Absorbent. And if you look at it, and if you have it in your site, it's acrylic. So it's like it has 2 layers between it. And in that layer, if you've got some exudate from like a stage 2 pressure injury or a little wound on their bottom or leg or something, you can put it on and it will collect the exudate in that almost like a little baggie, heal the skin underneath. The nice thing about it is it's strong, so that when you're repositioning the patient, we put it on a lady on her bottom one time. She had developed a wound, just she had through space so much and her skin had opened up. And we put it on her bum, and she said, oh my goodness, she said, it doesn't hurt to reposition anymore. So it can be used for pain too as well. And you can keep that one on up to 21 days, and that is if there's not a lot of exudate. When it goes to the wound edges on it, then you need to change it. So you see that picture there. That is a patient who developed a serous blister, as you can see. And what you could do for that, you can either let it deflate on its own, or you could, it's kind of small, but You could wipe a web ball over it, use a sterile needle, deflate it, and see. Excuse me, and just like paint it with betadine or leave it open to air. But you know that's going to break eventually. It looks like it's ready to break right now. So lots of choices for that, again, to keep it clean, prevent infection. We did end up poking that with a sterile needle, deflated it, and I think we just put some polysporin on it and it healed just fine. You could even leave it dry and it would heal on offload. So the next category is hydrocolloids, and they're for low to moderate discharge. And again, it's for protection, and it can be used with reddened skin, superficial, can be used as a secondary dressing. The one that we use all the time, hydrocolloid, we tend to use the Duoderm Extra Thin. You can put that on a vulnerable area on their coccyx, and you can leave it on for up to 7 days until it starts to wear down. Another thing too is if you have a small wound on a buttock, you can put that Duoderm hydrocolloid, and I don't work for any company, but I am using the name because I think it's more familiar for me to say a Duoderm Extra Thin versus to say a hydrocolloid. But all companies have them, so maybe I should say hydrocolloid. And the hydrocolloid, it can be used for reddened skin and for superficial skin breakdown and to prevent further breakdown. Again, the most important thing is to offload that skin and keep it healthy. And the dressing, you should extend it a few centimeters beyond the wound edge, again, to protect all of the skin. So that one there, do we have a question for that, Kathy, or no?
No, we don't.
Okay. So that is an unfortunate incident where a lady was living at home by herself. Her son had wanted her to get a lifeline, but she refused. She was a heavy smoker, brittle diabetic, and she had a fall at home and tripped and fell, sat on the floor for a few days. And so it looks like a burn to her bottom, but what it is it's ischemia. It's from dead tissue from laying in the same spot for 3 days before being found. And of course, with that comes dehydration, incontinence, etc. So what could you do for that one? Eventually that black will need to come off. She was admitted to the hospital, started on IV. I believe she was started on antibiotics, and we I think I just put a Duoderm over that until the doctors and plastics seen her. And eventually that sloughed off. There was some debridement involved, and she did heal. Again, a very, very long heal because of her age. She was in her 80s, and she was a brittle diabetic. But that did heal. Okay, so now your category is absorbent products. So you're looking at things with moderate to high exudate. So your wounds that are draining a lot. And you would look at foams, and many companies sell them. That one there is showing a Mepilex border or a Mepilex non-border. So any foam is good for highly exudating wounds. We don't use skin prep very often because it has alcohol on it. We would use a skin prep that is alcohol free, such as Cavalon or whatever. You would put that dressing over a wound that's highly exudating, that has a lot of drainage, and extend it a few centimeters beyond. Border dressings are waterproof. They should not be cut. The non-bordered, when would you use that? And put them, maybe tack it with some Hypafix or breathable tape, would be if that silicone foam dressing was holding too much moisture. And they can be left on up to 7 days, and sometimes people will put a foam dressing on the coccyx or on the heels, again as a protectant. So the next category are alginates. And in addition to managing the discharge, it's used for localized minor bleeding. If you have a wound that's bleeding, if you put Keltistat on it, it's got some seaweed properties in it as well. It will actually really help to stop that bleeding. So alginates are good for that, and you would cut to fit the wound. The other ones below are hydrofibers, and every company sells it. If you type in hydrofiber, I'm not sure what companies you deal with, you would get something that primary indication is for collecting drainage. You can cut it to fit and a little bit bigger. You can use ribbon ones that will collect the exudate. Again, you leave a long wick and use one piece. And they can be left on for up to 7 days. I don't recommend anything that you're packing be left in for 7 days. I don't like to go any more than 2 to 3 days. Hypertonic is another category that is losing favor the last few years. For those of us older nurses, we would see it more in the past, and hypertonic, just as the name suggests, it's used for moderate to heavy exudating wounds, including yellow slough. You would not use it on low exudating wounds or granulating wounds. It's 1/4 salt. So that is why it has lost favor and vogueness, and we'll be taking it off our chart, I hope, when we update the chart, and it comes in a ribbon as well. And the reason why is because if you have got something that's 1/4 salt, you can look at burning, right? So we tend not to use it very often. I think I've only used it twice in 2 years. Intrasite gel is just an example of a hydrogel. And what it is 80% water, and this is just an example of one. But any hydrogel, many companies sell them. Their goal, again, is to hydrate and moisten that wound. Oftentimes, we'll use a hydrogel with calixamir, such as iodazorb. We'll mix them together in a 50-50 little cocktail. The calixamir or iodazorb is one example of one. It has iodine-based products in it, kills biofilm, and helps to get rid of that slough. Adding the hydrogel to it gives it the moisture to do that. And excuse me, you wouldn't use it on highly exudating wounds because that defeats your purpose of adding that moisture. And there's an example of the calixamir iodazorb that we would use with it. Aquacel AG Extra is an alginate dressing that again is going to promote wound healing. AG, when you think of AG means there's silver in it. So that silver is going to kill the bacteria. And that can be left on. It comes in a ribbon as well. And there's lots of alginates with silver in it. This is just one example I'm showing you. Again, I work for no company. But they tend to be, they all work on the same premise. They're good for exudating wounds with bacteria that you want to kill. Anything with silver in it, you would see AG means it's got silver in it. So you would not use with patients with known sensitivity to silver. The next one here, this is polyhexamethylene biguanate. So we just call it PHMB. And it's for wounds with signs and symptoms of local wound infection. It's broad spectrum topical antiseptic. You would use it on anyone who's got an allergy to PHMB, and you would not use it with Dakin's or bleach solution. Cut to fit. You can moisten it with normal saline or for a hydrogel. I would just go with normal saline instead of wasting my money on a hydrogel for that. But the polyhexamir biguanate, it kills bacteria like staph and MRSA. And it also, if you have a patient who's got Pseudomonas in their wound, and a Pseudomonas you would know, you'd recognize it because it's got lime green staining in the wound, and there's a little bit of an odor. So some facilities, if they see Pseudomonas in a wound, they'll do a swab and start them on an antibiotic. Well, we try to avoid starting people on antibiotics if we can treat that Pseudomonas and kill that bacteria at the local site it's at. And we have had great luck for the last several years getting orders for vinegar soaks for Pseudomonas. So Pseudomonas is a bacteria that you'll see, it's like lime green staining in your wound. and it has a little bit of an odor. I had a patient that I saw Friday night in Emerge. He came in with a wound, and when I took off the dressing that he had been using at home, caring for himself, and he had just was putting dry dressings in from when he had before, there was lime green staining on the wound, and it was very foul smell because it wasn't being treated with anything. And we got away with doing vinegar soaks on him 3 times a day, and we tend to use a tablespoon of vinegar to 1 cup sterile water, and you can go up in strengths deciding upon which order you go. With him, because it was quite significant, we did 20% vinegar, 80% sterile water. We took a 500 ml container of sterile water. We took out 100 and put in vinegar, just plain white vinegar, and added it and labeled it. And they soaked the gauze, put it in the wound 3 times a day for 3 days. When I came back on Monday, all that lime green was gone and a lot of the bacteria was killed. So it really cleaned it up. So vinegar soaks can work well to kill Pseudomonas. I went off track a little bit. But this PHMB, and I'm going to show you this package here, it's antimicrobial dressing. And I will share the name. It's Covidian, and I only share that because it's to my knowledge, it's the only company that currently has this product, the polyhexamine biguanide, and it comes like in a Curlex, and it costs $3, all of $3 for all of that. So this product is beautiful for signs and symptoms of local wound infection. It will also, if you've got a patient that's quite heavy and they've got redness underneath their groins, and it tends to be moisture, and then we put the creams underneath it, and if you put too much cream it becomes more soupy, and you're just kind of going around spinning in a circle. We will clean underneath the groins, underneath the pannus, underneath the big skin folds, dry it, pat it dry really well, and we'll cut some of this up and we'll tuck it underneath their breast or in their skin folds. I've seen us use it for severe diarrhea. If babies have diaper rash, you can put that right in their pamper and it will clean up that redness in 24 to 48 hours. And it's a lovely, inexpensive product that works very well. We use it for a lot of things. And it's great if you've got those deep wounds. You can see once it's wet, it would go really thin, so that you just have one layer as well. So that's polyhexamine biguanide. It's an antimicrobial. It comes in smaller packages as well that are like 1-inch ribbon, 1/2 inch, and 1/4 inch. So that's an example of the antimicrobial dressing. I'm just showing you some pictures of that. This here is, these are another example of silver products that could be used for wounds, donor graft sites with signs and symptoms of local infections. This one here is a flexible. It's just loaded with nanocrystals, so it's loaded with antimicrobial to kill bacteria. You would never use it on a patient who has a silver allergy or exposed internal organs, but we've never ran into that one, thank goodness. But it does need a cover dressing. Inidine, I'm sure most of you are familiar with. It's, again, it's an antimicrobial in that category of wound care products. And it's for topical antimicrobials for shallow wounds. And as you can see, if you look at it, it's kind of coppered color. I'd love to ask how many have used it. Can we ask that question, Kathy, or is that too hard?
Yeah, well, they could just pop in the Q&A there if you've used this before. Just have a peek. So we have a bunch of people saying yes, that they have used this before. Good. Yeah, some many times. Yeah, so quite a few have.
Oh, good. Yeah, so we're right up to 142. I love it. 144. Great. So it's an inexpensive product, costs a couple dollars. It's great for if you've got some skin breakdown or a skin tear that's not open. You can put it over the area. The nice thing is it doesn't stick to the wound. And it has iodine in it, so you got to be careful because it can be stingy, but most people have never complained about the sting at 146 we're up to. And you would change it. People ask, well, when do I change it? It can be left on for up to a week. But I change it, I always say change it when it turns white. Because once it turns white, then it's used up all of the antimicrobial. So the fading of the color indicates the loss of the antimicrobial activity. So it's a product, any product with topical antimicrobial with some iodine in it. This is one example. Inidine can work well for shallow wounds. And this is just an example of skin glue. And shoot, I thought I had another one here. So I'm just going to show you another so that I don't think I'm any. This is another one. And when would you use skin glue? We're using it more and more now for skin tears, and I'm just going to show you how it works. It almost looks like a marker, and then what you do is you hear me snap that seal, you squeeze the glue onto the end. I'm actually going to I'm going to pretend this is a skin tear, and you have to let it come to the bottom. And you would put on layers. And it looks like, remember years ago they used to advertise crazy glue on TV? This is basically, it's a safe a skin glue for the skin. So if you have a skin tear where you can approximate the edges, you would have one worker pull the edges together and the other one would apply it along the edge. I would do three applications, let it dry a little in between, and don't touch it for a few weeks. And it's beautiful for healing those skin tears, and great for the elderly. So people say, well, do you put anything over it? Nope. It'll dry, and it almost looks like clear caulking. And it will eventually, weeks later, come off, and it'll be nicely healed underneath. So there are two examples of skin glue. And again, you would put it on in strips. Try to do 3 layers. For extra protection. So what type of wound would that be? And what kind of treatment? We don't have a question for that, do we, Kathy?
No, we don't.
Okay, so I'm just going to tell you that is an ankle wound, as we can see from the location. And the patient is a diabetic and had callus build up, and it's from rubbing against her shoe. And she was so busy looking after her family that she neglected to look after herself. So you can see it's too wet with all the white around it. So what I did was I took all that callus off and cleaned it up, and you can see, gosh, how much better that looks. So then you're thinking, well, what could I do to keep healing that? You can do a lot of different choices. You could use a silver product with an alginate and put that in and put a cover dressing on it. And you don't always have to use a foam dressing. You could even put gauze and Hypafix around it. Again, the biggest important thing is to make sure that she's got the circulation for wound healing. Check her pulses. And then I change that a couple times a week if I was using a silver dressing with an alginate. And that did heal up. You have to remember too, with the elderly and with diabetics, their wounds take forever to heal. And sometimes we want it to heal faster because we care so much and we've invested in this, but we have to remember that a 20-year-old wound compared to an 85-year-old wound, we're looking at months of differences in healing. Okay, Meta Honey, this is the product that we talked about. And basically, that is what looks like, and what it is, it's a duoderm, so it's a hydrocolloid that's embedded with sterile honey. And what that does is you would cut it to fit the wound, and it kills and eats all the bacteria in the wound and helps it to heal. At first, healthcare workers don't like it because they'll say to me, oh, it's so runny, I had to change that dressing twice the first 2 days. When you first start using it, if you want to use it to clean up a wound, if it's kind of getting like dirty or draining a lot, that's a really good sign. That tells you that that Meta honey is doing its trick. It's doing what we want it to do. It's cleaning up that bacteria. I tend to put another cover dressing over this, even though it's embedded with the hydrocolloid, just again to collect the drainage. And I just use gauze, it's inexpensive. And if I'm worried about tape around the skin, I'll wrap some Curlex around it. Meta honey can be left on for a week, but we tend to change it the first week 3 times a week and thereafter twice a week. And it's very effective. Okay, so ideas where this would be useful. This is similar, this product is similar to this one. The antimicrobial Curlex that I'm showing you here. This is a moisture wicking fabric, which has the antimicrobial silver, and it almost looks like saran wrap, and it comes in a roll. And what you would do is you would cut it off, and again, you're going to put it underneath people who have large panis, groins that are broken down. I put it on, like when you see someone's groins that are broken down, if they've got stage 2 pressure injuries, I've tucked it right in there. The important thing with this moisture wicking fabric, and Interdry is just one example, is that you leave a 2-inch wick to the air. So don't tuck it into a groin or in a buttock or any area where it's not exposed to air, because it needs to wick it out, just like our wicking clothing that we have now. So leave a nice 2-inch wick so that it can evaporate and take that moisture out of that wound and evaporate it into the air. And that can be kept on. We usually change it every couple of days, but you're going to change it as you need it. If it gets wet in that, sometimes people will take it out and they'll hang it to dry and reuse it. It can be reused like that. We tend to find that it gets soiled from the areas, but the biggest thing with that is to leave a nice big wick. Any questions about that product? Am I allowed to ask questions?
Of course. I don't see any questions right now specific to
Okay.
that. Oh, well, you know what? There's a question here. Sorry. In the past, we have used Intradry for patients who have had redness and excoriation for under breasts, groins, penis. Would you recommend using the antimicrobial Curlex instead of the Intradry?
Do you know what? That's a great question. And you can use either. If it's a matter of cost, I'll be honest. This Curlex is $3 for a whole bundle. And it has the antimicrobial in it, where the Interdry is more expensive. So if we're looking at cost, they both do the same thing. They can be used interchangeably. And if your facility is looking at cost and affordability, the PHMB Curlex will do the same thing for a little bit of better price. So great question. Yeah. Any more questions on that one?
There's one here that just asked, how do you know if a patient is allergic to silver or not? I don't know if you want to answer that now or.
Yeah, they usually know because they're allergic to sulfa drugs. That's a great question. So if they're allergic to sulfa drugs, chances are they may have an allergy to silver products. But I've had people who are allergic to sulfa drugs who can tolerate the exterior. Yeah.
And there's one more. Oh, sorry, go ahead.
Nope.
I was going to say there's one more question here that if we hang it dry and use it again, does it harbor bacteria?
Pardon me, it's supposed to, because of the antibacterial properties within it, it's supposed to kill it. But I find that like you can rinse it out with tap water and then hang it. So it shouldn't be harboring that bacteria. That's what Cassie Esligar used to do with them. Now I find that when we use them, they tend to get so dirty, we tend to discard them. But there is that option.
Okay.
We'll go to the next slide. Okay. So this is a patient who came in. She has MS and she developed this bed sore on her bottom. and we had it almost healed. She went home and she admitted that she spent too much time in her wheelchair and it ended up going to a stage 3. So I was just going to ask if a few people wanted to make a suggestion of what we could do for this wound, for a product to heal it up, besides offloading, of course.
Sure. If anybody wants to type how you think you might treat this, I guess is the question. What would you
Yeah.
do besides offloading? If you want to type it in.
We should, Kathy, you should be giving prizes, you know that.
Yes. So one says Inodine, one
Yeah.
says Medihoney.
Yeah.
Inodine again. Couple
Yeah.
votes for that.
Yeah. Great choices.
Yeah.
Inodine and offloading would work.
There's
Meta honey, I kind of like the idea of meta honey because it's got, it looks like it's a little bit more than superficial, and I think it would clean it up nicely. Yeah.
yeah, there's a couple that have said Tegaderm absorbent dressing or a
Yeah.
Meplex.
Yeah. If I was going to use the Tegaderm absorbent, so it's a silicone with the 2 layers in it, I would put the Inodine on first because if you look at that wound, it's got some yellow sloths in the middle. So Tegaderm absorbent's a great choice, but let's clean up that yellow too. So let's put the Inodine on and then put the Tegaderm absorbent on and keep it on till it turns white.
And 2 little questions with this one. One person is asking if this would be a candidate for a Pravina.
Okay, so a Pravina is a negative pressure wound therapy that's sold by 3M, and it's a disposable. You can put a little a Pravina. You put the sponge on it. You just put the sponge on it. It connects to a canister which will hold 45 mils of solution, and it costs $700 for that 1 week.
Ooh.
So, if that healthcare facility is able to afford that, yep, that would be an option. It wouldn't be my first option because of the price, and I think we can heal this up. I don't think it's deep enough that it needs negative pressure wound therapy, and again, it's because it's disposable. It's $700. It probably wouldn't be my first choice, but it's not a bad choice.
And then someone else asked if you would ever use Triad.
Triad on that.
Yeah.
I probably wouldn't because it's a little bit deeper than the picture shows. But Triad is a it's a hydrophilic. It's got zinc oxide in it. It's got some glue in it. It's got some antibacterial in it. It's I'll show you it right now if I can get it. I think it's a little bit too deep for Triad, but it's not a bad, not wrong. It's not wrong. I just think you would have more success with some. I don't have any of it right here. When I stop looking, I'll find it. Triad would probably not be a great choice for this because I think that people would be putting it on too thick. I think the wound's a little bit too deep. And with Triad, the most important thing with that is that you just use as little as possible, pea-sized amount, and only put it on the area. That's the problem we're having with Triad, is that people are putting it all over the area when it doesn't need to be. It's only indicated to people right on that wound. And it dries and acts as a cover dressing. So with Triad, you do not need to cover it.
And
But
just
it probably wouldn't hurt it. Yeah.
okay. 2 more questions about this one. Is someone's just asking if Alevin would be appropriate?
Alevin, yeah, I'd put some Alevin in. I'd probably want to add a little bit of antibacterial, like clean up that yellow. But you could put some Alevin in there. Alevin is a foam dressing.
And then lastly, would just using a Tegaderm plain on the discolored area be a good choice to protect the unbroken skin?
For sure. Yeah. Yeah.
Okay.
Thank you. Great questions. So this here I just wanted to share with you is for minor to severe irritation due to incontinence. So this is a Coloplast product, and it is it's kind of gritty when you use it. And I'm not advertising any products, but It's really nice for the relieving minor skin irritation and incontinence associated dermatitis because we tend to have it. And if you look at it, I'm better if I pull back. Again, you just need a little bit. You rub it together, it feels a little bit gritty. So you would put a thin layer. I'm going to pretend this is my bum. And I've got incontinence associated dermatitis. You can see how thin a layer I put on that. And that's protected. It's got Vaseline in it. It's got a little bit of, what is the other active ingredient? Forgive me here. Active ingredients is it's really 71% petroleum, but it wicks away the incontinence like diarrhea and that. You know, sometimes we'll have to put someone on an antibiotic and they have terrible diarrhea. And so for that, the incontinence associated dermatitis, you know, again, clean them as often as you can, toilet them if you can. But this is a really nice skin protector for that incontinence associated dermatitis. Okay, so this is a lady who came in to see me the other day. And she is, we're talking about critical colonization. We talked about infected wounds and putting silver and antibiotic. It's a choice of the physician. Whether to swab it or not is, again, you would ask if they want the wound swabbed. The big thing when you're taking a wound care swab is to clean your wound really good with saline and pat it dry. Get all that yellow out of it so that you're not swabbing. Sometimes years ago we used to, get that wound swab right into that yellow exudate. No, the big thing is to get rid of that yellow if you can. Clean it, pat it dry, then take your wound swab to see if there actually is bacteria in the wound versus just the slimy exudate that's coming off. So that's important when you're doing wound swabs. So critical colonization means if you've got a non-healing wound, you've got more exudate, it's red, it's bleeding, if there's debris and a smell. And then we look at, is the size bigger? Is it temperature? Does it probe to bone? Is it new breakdown? These are more deeper, longer wounds that are in trouble. And so that's why when we talk about critical colonization is when they've gone from an infected superficial to this level. This lady came to see me the other day. She had had the wound for 10 days. She had actually hit it against her vacuum cleaner. She is a diabetic and she does not check her sugars. No, I'm sorry, she's not a diabetic because I keep asking her if it's a diabetic. This is her lower leg. She hit it against the vacuum cleaner. It started out as a skin tear. She covered it. Her daughter must work somewhere in healthcare because covered it with gauze. And then they did use a Tegaderm absorbent, but as you can see, it needs to be cleaned up before that will heal. She has poor circulation. You can see in her leg is red. And she has what's called hemocedric staining. So if you see patients and they've got like a brownish discoloration of their lower leg, that's called hemocedric staining. And what that is where your pump flow, you're pumping your blood is going down to your feet, but not coming back at the same rate of return. And that's where you need the compression to help that blood flow. So she has hemocedric staining. You can see it a little bit at the lower end there and the redness around it. So this wound had been in existence for about 10 days. So at that point, I'm worried about more than just a local infection. So I sent a picture to her physician, and he chose to put her on a prophylactic antibiotic. And I cut away the yellow. And for that wound, I put her on calhexamine. And that is a product that would kill the biofilm. Because at this point, it's shiny. You can see that it's more than local bacteria. So calhexamine, another name for it is iodosorb. And I used the powder, put it gauze, sent them home with her daughter. And she came back on Monday, and about 30% of the slough was gone. Because of her history of poor circulation and that, I sent her to see Dr. Schaus, who works locally in the area, for further debridement and management. Okay, so with all wounds, good. So we finished our chart. We've talked about some products. Good nutrition is absolutely essential. If we're not getting enough protein in that in our diet, we're not going to heal. We need a hemoglobin above 90, really. Less than 100 is impaired with wound healing. Watch our sugars. If your sugars are above 10, I always say it, just think of it as that stickiness preventing the circulation to heal the wound. Correct dehydration. Find out what caused the wound and consult others. So, incontinence associated dermatitis, I'm sure we've all seen it in our practice. And just to remember, it's a top down injury. Damage is started on the surface of the skin, where pressure injuries are believed to be bottom up injuries, where damage is initiated with changes within soft tissue. So, we're going to talk a little bit about pressure injuries because they're so very common. Localized skin damage, usually at a bony prominence or related to a medical device. We used to use the term pressure ulcer. In 2016, the National Pressure Ulcer Advisory Panel replaced pressure ulcer with the term pressure injury to give it a better indication. I'm looking at my time of what it really is, and it's an injury. So I just put this slide up because most of you are probably aware, but Christopher Reeves, who did Superman, was Superman. As you know, he had a horse accident years ago and became a quadriplegic. And he died because of complications of an affected pressure injury. So, pressure injury monitoring is an indicator of our quality of care. There's nothing worse than finding a resident that has developed a pressure ulcer while under our care. Nobody wants that. And I just threw that in there when we talk about documentation. It says I've reached a point where I'm spending more time on paperwork than patient work. And sometimes we feel that way, but it really is important to assess our skin. True or false? Pressure sores can begin to form as short a time as 2 hours. We don't have a question for that one, do we?
No, we don't. No.
Okay. So the answer, the answer for that is true, if you can believe it, with compromised skin. As short a time as 2 hours if they're on pressure. Is there possible to achieve zero pressure injuries at your site? Yes, it is. And that is by being really cognizant, checking your patients, toileting, turning and positioning, watching the nutrition. It can. Most pressure injuries are avoidable. True or false? It's true. We can prevent up to 4% of pressure injuries. And those 4% are usually those palliative patients who have stopped eating, etc. They have such poor circulation that they are the ones that are unavoidable. So, true or false? We are responsible in Canada to report all stage 3 or greater pressure injuries as incident report. And that is true. That comes from our Never Events for Hospital Care in Canada, Safer Care for Patients. And that's been in existence since 2015. So if we have a resident or patient that's developed a pressure injury at our site, if it is stage 3 or greater, we're responsible for reporting them. So I'm just going to click on this and pray that this works. And this is a patient at a deck, pressure injury developed, settled at a court. And he says the hospital should be prepared for patients like us. So I'm just going to play it now.
And it hit me right away because I went through the same thing. I had pressure sores also, and there was just no need for it actually. Well, I went to the hospital actually in Fredericton at the Chalmers because I had a kidney stone. And whenever I have a kidney stone, I go there, and I'm there about maybe 10 days. So I didn't have no monkey bar. Now, a monkey bar is something that you get a hold of to lift yourself up in bed. And I didn't have that. So I kept, grabbing the handlebars of the bed. and I kept dragging myself on the bed, and that's how it started. The hospital should be prepared for it, that the people like us were prone to pressure sores, and we have to be observed closely. I just wanted people to know what happened so they wouldn't have to go through the same thing that I did.
So that was presented on the CBC News a few years ago when they had the big case in Nova Scotia of the lady who lived with Down syndrome who developed a pressure injury. So bottom line is majority of pressure injuries can be prevented. We failed this gentleman when he came into the system. This was years ago. And he had asked for a triangular bar for his bed when he came into the hospital because he was being treated for kidney stones. And staff said, we don't have it available, can't get any. So unfortunately, that's not acceptable, as we all know now. Today, then we should then too. So he ended up with friction and shearing with a pressure ulcer on his bottom. He successfully sued the hospital, and it was settled out of court. So I'm surprised that it went to the CBC where it was settled out of court. But again, if you have a person who is a paraplegic and requires those tools, to say we don't have it is not acceptable. We have to get those tools in for that prevention. So we're just going to go over staging of pressure injuries and blanchable versus unblanchable. And that's where we have our heels, our toes, if you blanch it. And the pink, and you can do this with your own finger. If it doesn't come back to white, that's called non-blanchable, and that's a stage 1 pressure injury. And you can see it develops on the heels very often. Excuse me. So stage 2 is partial thickness skin loss with exposed dermis. The bed is pink, red, and may be intact as a serum-filled blister. An example of that. Oh, okay. And that would be an example of a stage 2. A stage 3 is full thickness skin loss, where the fat is visible in the ulcer. Depth varies. Undermining and tunneling might be there. You won't see fascia, muscle, tendon in stage 3. Stage 4, you can see how it goes down to all 4 layers. If slosh or eschar obscures the ability to see it, then we would, like if it was covered black, then it would be unstageable, right? So that one right there, oh, I'm sorry, I'm going to go back. That one there is actually a stage 4. If we were using our Q-tip, it would tunnel in about 4 centimeters. This one here is unstageable pressure injury. And as I showed in my beginning slide, we don't know how deep it is because the slough is covering. A stable eschar, it's dry and intact. If it's on a heel and they've got a black heel, you have to think about the cause of that. Some people are so tempted that needs to be debrided. But chances are it's ischemic, which means there's not enough blood flow there, and that's why it became black in the first place. So you would never, ever get someone to take or try to take that black off. What would you do instead? Can we have a few people with suggestions?
Yeah, if you guys want to type in your suggestion. So we've got offload, of course.
Yep.
And inodine. Keep
Yep.
it dry and elevate it.
Perfect. Yeah. And what we tend to do with those black heels is you can just paint them with betadine. Betadine or iodine or whatever company name. And again, offload, offload, offload. And it will eventually peel off. Check to make sure they have pulses. But it will take months. But you would not, if it's an ischemic limb or heel, should not remove it. Do not remove it. You'll end up with a great big infection and they could potentially lose their foot. So this is an example.
So Nancy,
Yeah.
Sorry, you're all of a sudden your volume's got a lot of background noise. I don't know if other people are hearing that. Do other people hear that, or is it just me? Yes, people
Yeah.
are hearing it. It's like a crackling or something in your background all of a sudden.
How is it now?
It's still happening. Oh, no. Like I can still hear you, but there's like a crackling in the background all of a sudden for some reason. But I guess we'll just continue on.
Would it be easier if I talked louder or lower?
Maybe a little louder.
Okay. Sorry about that. So I'm going to ask that we stage these pressure injuries. And this one, I think we all know is unstageable. And again, you don't want to take that off. You want to paint it with betadine, offload like you've stated, and let it heal on its own. Try to improve the circulation if possible, and offload. Our next slide I think we all know that's unstageable again. This is another lady who fell in her apartment and wasn't, it was her apartment, and wasn't found for 3 days. And this is what developed. So that's an unstageable pressure injury. It did eventually heal. It took 1 year and 6 months. It needed to be, she came in, it needed to be debrided by a plastic surgeon. And then we did use the negative pressure wound therapy to heal it. And then we ended up using an alginate with silver in it. But it took a year and a half to heal it. She was almost 90, a brittle diabetic, very malnourished, and not great circulation. Okay, so if you look at the top of her back there, what would you stage those as? They are non-blanchable. If you chose stage 1, you would be correct. These ones here are another bottom. Unfortunately, the most common place for pressure injuries. Second is heels. And those are unstageable. We don't really know how deep they are, but we know that that lady is not being offloaded very well because you can see all the redness and pressure around. This one here, what would you give that? If you said stage 2, you would be correct. That one again is stage 2. It needs to be cleaned up. You could wipe that with some, sorry, please excuse me. Wipe that with some gauze, with some saline. Try to get that yellow out and put a dressing on it of your choice. Excuse me. That one is a red bottom, just from being on the bedpan too long and repositioning, and that's stage 1. For stage 1, you really want to offload. Watch your time on the bedpan and really protect the skin. You could use a skin barrier with non-alcohol in it. I would probably just leave that skin and monitor it and offload. Sorry. You can see this one here, what's going on with this leg is you can see the edema on the lower part of the foot, and that patient had compression on, but instead of starting the compression at the toes, it was started halfway up the foot, which led to the edema. So if you're using the compression wrap, you always start at the toes. That one there, stage 2. Okay, any questions about staging the pressure ulcers, and do you have access to pressure staging cards? If anyone does not at their facility, please let Cassie know, and we can certainly send you our tools. I'd also encourage you to use the braiding scale. This is the tool that we have at our facility. It just shows the 4 stages with definitions. And then on the back of the pocket card that we give to all of our new nurses, on the back of it has the Braden score. And the Braden is a tool for risk assessment for skin breakdown. And the Braden is divided into 4 categories: activity, mobility, nutrition, friction, and shearing. And and then it determines your risk. And then you would do your interventions that you've already all talked about to prevent it. So this is one lady's experience here in New Brunswick that did go public with the CBC that I felt was quite moving that I'd like to share with you.
So I don't want it to happen to nobody else. Like what happened to Mom? She went in for a broken hip, and her hip, even with the diabetes and everything, it really healed up really, really good. And she ended up with a bed sore. Stage 4 bed sore, and we're losing Mom. Now Mom should be home, eating some good cod fish and having a good time with her family. I took it in my own hands to go investigate what this smell was coming from. And we thought it was maybe the cut. We didn't know how bad this bed sore was. But when I took the bandage off, the bed sore, there it was. And it's just, it totally freaked me out. And I'm talking about it today, I want to cry. But it was bad. And we're sitting in the room, and all the nurses that are coming in, what's this machine? How do you work this machine? What does this machine do? Nobody had ever seen the machine.
Is it often? I hope not. But still, depending on the health condition, on the quality of the skin.
What has it been like for you in all these different hospitals? You want to know? Disappointment.
Any questions or comments about that? That's a lady who went in for, she had fractured her hip and was not turned in position and mobilized, and started out with stage 1 pressure injury that progressed. Any questions or comments about that?
Not in particular that. Somebody was just asking earlier if you had small cards that you can keep in your pocket so you can compare it when you're in the room.
Definitely, yeah. Like, that shows the different pressure injuries.
Mm-hmm.
Yeah, I do, and I'll send you an electronic copy, and you can share that with
Sure.
whoever was inquiring. Yeah.
Yeah.
So we can see how something as starting out with red skin can progress with poor nutrition. I'm sure she was not moving, obviously, for her to get to that bad. This lady died about 8 months after that was viewed in the CBC. So I share that with people to all of us to remember that pressure ulcers do occur in all hospital settings, and we really need to check patients' skin and be proactive in prevention. So that's it for that one. Can we take we're almost at a time. Can we take a 5-minute break and then we'll run through skin tears?
Sure. Sounds great.
Okay, thanks everybody.